to send one marking score sheet there. I just shared on the group, ma'am, the scoring
Right.
sheet.
I got it.
Yeah. Gurudasani sir also has joined. Good morning, Gurudasani sir. Good morning, Manjunath sir. Good morning, Chaugule sir. Sir, mute him, mic तुम. Yes.
Dr. Sumit. Am I audible?
Yes, sir. Voice थोड़ा कमी है. थोड़ा है.
Oh, okay. Yeah. Is it okay now?
It is better, sir, but I'm getting.
Hello.
Yes, sir.
Yeah, it's okay now.
It's okay, sir, but little low. You can take your computer
I'll
little
speak
close to your
louder.
face. Yeah, then that will be better. Good morning,
Yeah.
Manjunath sir.
Good morning.
So, Dr. Sumit,
Yes, ma'am.
as we just received the score sheet right now, what I'll do is I'll fill it in draft.
Will do, ma'am.
I'll have some time to send it to you, right?
Yes, ma'am. Yes,
Afterwards.
ma'am. You till evening also you can send, ma'am. There is no hurry.
All right.
Later in the
Okay.
day only we will mail because we have to compile all the 8 sessions winners and then we will mail
Right.
them personally.
Okay. All right.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Are the speakers logged in?
I'll try and connect with them, those who have not joined. Just give me a 5 minutes. Good morning, Mania sir. Ranjit Mania sir also has joined us.
Good morning, everyone.
Good
Should
morning,
I start?
everybody.
Should I start with
One
my
second.
presentation?
Now, 1 second. Good morning, everybody. Welcome to session 14 of free papers of BOA MOS webinar. I'm Dr. Vidyasagar Chaugule. I'm a moderator for today's session. Are all the speakers there? Is Dr. Ankita Siak there?
Yes, sir.
Dr. Purva Kher?
Yes, sir.
Dr. Mansi More?
Yes, sir.
Dr. Jinil Bhatt?
Yes, sir.
Dr. Sneha Kukreja?
Yes, sir.
Dr. Mili Arora?
Yes, sir. Good morning.
Yeah, good morning. Dr. Nishika Jain?
Yes, sir.
Yeah, fine. Very good. At the outset, let me first introduce our judges. Our judges for this session are Dr. Manjunath Patil. He is a professor and HOD of Department of Ophthalmology, Ashwini Rural Medical College, Solapur. He is also pediatric ophthalmology as a specialist. Dr. Sarika Gadekar from Aurangabad, cornea and refractive surgery consultant, professor, Professor, Department of Ophthalmology, MGM Medical College, Aurangabad, and Dr. Bhavisha Gurudasani, Associate Professor, GMC Medical College, Akola. Let's start with the presentations now. Is it okay with the judges?
Yes. Yes.
Yes.
Each speaker will have 6 minutes for their presentation and 2 minutes for discussion. Shall we start with Dr. Ankita Siak?
Yes, sir.
Yeah.
Good morning, everyone. I'll be presenting a case of herpes zoster ophthalmicus with corneal perforation, which is a rare manifestation. Introduction: herpes zoster ophthalmicus, which is known as shingles. It's a viral disease characterized by unilateral painful skin rash with radicular pain in one or more dermatomes, distributions of the fifth cranial nerve, that is trigeminal nerve, and it commonly manifests as eyelid lesions, corneal disease, or uveitis, which can entail a myriad of long-term sequelae. Typically, it occurs in older adults, but can present at any age and occurs after reactivation of latent varicella zoster virus, which is present in the sensory spinal or cerebral ganglia. Etiology: reactivated varicella zoster virus from its dormant status in the dorsal ganglion cells of the CNS. From there, it may travel along the neurons to the sensory axons of the skin to form vesicular lesions. Risk factors are virulence of the varicella zoster virus, immune status of the host, age more than 60 years, racial factors, recurrence, prolonged illness, and chances of myelitis and vasculopathy are more in immunocompromised patients. High risk of varicella zoster virus is present in HIV patients. General pathology: varicella zoster ophthalmicus is a double-stranded DNA virus in the herpes simplex virus group. It is due to activators. Herpes zoster ophthalmicus is due to activated varicella zoster virus. Pathophysiology: reactivation of the virus from its dormant state in the sensory ganglion, which leads to replication in the nerve cells, and then shedding of the virions from the cells that are carried down the axons to the skin served by that ganglion. The local immune response is responsible for blisters or ocular inflammation. Perineuritis is responsible for intense pain along with the nerve distribution. Paresthesia and segmental pain can be present before the onset of rash in that area supplied by trigeminal nerve. Aging, immunosuppressive therapy, and psychological stress are the factors responsible for the activation. In my case, a 65-year-old diabetic male hailing from Malana village presented to the OPD of Malana with the complaint of fever since 12 days, burning sensation on forehead and around the left eye since 12 days, vesicular eruptions on that area of the face since 10 days, discharge in the left eye since 10 days, diminution of vision. He was complaining diminution of vision since 10 days, which was followed by sudden loss of vision since one day. History of presenting illness. Patient had low-grade fevers 12 days back, which was associated with headache, tiredness, and malaise. Pain and burning sensation on the left side of forehead and around the eye was present. 10 days back, eruption of groups of vesicle on the left side of forehead, left upper eyelid, and nose associated with itching and pain was present. Redness and mucopurulent discharge from left eye along with decreased vision, which was followed by sudden loss of vision since yesterday was present. Past history, there is no history of long-term illness, decreased appetite or weight loss. There's no drug history or known drug allergies. A patient had a history of chickenpox at the age of 12 years. Patient doesn't have any history of similar episodes of eruptions in the past. Family and social history, he's married and lives with wife and has 2 children and all are healthy. He doesn't have any addictions. He works as a farmer and belongs to a middle-class family. On examination, visual acuity in the right eye was 6/12 and in left eye, PL positive and PR inaccurate was present. On external inspection, erythematous skin with groups of flesh-colored vesicles with crusting on left side of forehead, left upper eyelid, along the lid margin, side and tip of the nose was present, which is suggestive of Hutchinson's sign. The lesions were localized to the distribution of first division of trigeminal nerve. Bilateral ocular motility was normal. Pupillary reaction. In the left eye, we couldn't appreciate the reaction. On slit lamp examination, conjunctiva, right eye is normal. In the left eye, hyperemia was present. Cornea. In the left eye, perforation with the iris prolapse was seen. Sensation could not be appreciated in the left eye and it was normal in the right eye. Anterior chamber was normal in the right eye and collapsed in the left eye. Lens was cataractous in both the eyes and fundus in the left eye could not be visualized and in the right eye it was within normal limits. This is the picture showing corneal perforation with iris prolapse along with mucopurulent discharge along with edematous eyelids. Investigation, patient was tested for viral markers and found to be negative for all the markers. Management. The patient came to the OPD with the 10-day history, 12-day history of his herpes zoster ophthalmicus. Patient was evaluated and investigated, and he was
1 minute left.
You have one minute.
Okay, sir.
You
And
have
he
1
was
minute. Yeah.
immediately started on oral acyclovir 800 mg 5 times per day. And on slit lamp examination, patient had a corneal perforation with iris prolapse. Patient was advised penetrating keratoplasty at higher center where corneal transplant is available. Discussion. Herpes zoster ophthalmicus occurs in 20% of chickenpox affected individuals and reactivation of virus occurs between 50 to 90 years of age. Patient presents with prodromal symptoms like malaise, fever, erythema. Ocular involvement occurs in around 50% of the patients. Ophthalmic complications include lid scarring, paralytic ptosis, conjunctiva, conjunctivitis, etc. Corneal involvement may be present as punctate epithelial keratitis, deciform stromal keratitis. Corneal anesthesia is profound in this case and often leads to recalcitrant neurotropic ulceration, which further leads to corneal perforation. Treatment modalities include oral acyclovir, which is given for 7 to 10 days and it has to be given within 72 hours of onset. Eye ointment acyclovir 3% can be given for 5 times daily, along with topical cycloplegics. Surgical modalities include penetrating keratoplasty. Conclusion, the management of herpes zoster usually involves a multidisciplinary approach aiming to reduce complications and morbidity. This case highlights the importance of an early referral of all patients with herpes zoster ophthalmicus to the nearest eye center. The treating doctor should be aware of all its associated potential vision-threatening complications, which, if not promptly detected and adequately treated, may even lead to a total loss of vision. Thank you.
Can I ask?
Judges can ask questions.
Sorry, ma'am, you're not.
That's Can you hear me now?
Uh,
Can you hear me now?
Ma'am, I can't. Sorry, you're not audible.
Okay. Am I audible now? Some other judge can ask a question. Then I think.
Ankita,
Ankita, audible now?
Ma'am, I can't hear you.
can you hear me, Ankita? Can you hear me, Ankita?
Ma'am, would you please repeat the question? Sorry.
No, I haven't asked a question yet. Some other judge can ask if you can hear me well.
Dr. Ankita, Dr. Gurudasan will first ask you a question.
Ankita,
Yes, sir.
the patient presented you at the 10th day. Do you rule out any inadvertent use of steroids or home remedies at home that
Yes, sir. I did ask him the history of any medication. He went to a local practitioner, but he doesn't have the. He didn't give me the history of using steroids from that place.
any home remedies?
No, sir. No history of any home remedy.
Okay.
Dr. Ankita,
Yes, sir.
did you read madam's question? It was, what is the prognosis of the transplant?
Since it's a neurotropic kind of keratitis, so prognosis will not be that good. There'll be chance of transplant failure because of the neurotropic keratitis.
Improve the prognosis.
Ma'am, by giving the oral antiviral, we can reduce the viral replication and we can reduce the viral. Ma'am, you're not audible. Sorry. This is done to cover the wound so as it can help in re-epithelialization, which can help healing the perforation better.
Our next speaker is Dr. Purva Kher.
Morning, sir.
Thank you.
Dr. Purva,
Sir, am I audible?
you can start.
A very good Good morning to everyone. I'm Dr. Purva Kher. Thank you, BO and MOS, for giving me this opportunity to present my case titled Evaluating the Role of Retrobulbar Amphotericin B Injection as an Adjuvant Modality of Treating Rhinoorbital Mucormycosis in a COVID-19 Patient. A 49-year-old male who was admitted in the ICU for COVID pneumonia gave history of swelling around the right eye since 2 days. There were no other ocular complaints or no significant complaints in the other eye. The person was a known diabetic with uncontrolled sugars being treated on steroids and also being treated for hypertension and schizophrenia. On examination, the general condition was poor, the vitals were stable, and he was maintaining saturation on BiPAP. On ophthalmic examination, vision in both eyes was finger counting 3 meters bedside with PR accurate. However, in the right eye, there was lid edema along with lateral restriction of extraocular movements and absent sensations in the distribution of trigeminal nerve. There were no remarkable findings in the left eye. ENT reference showed a black eschar in the right nostril and crusting in both nostrils, along with a palatal ulcer which was present. HRCT thorax was typical of COVID pneumonia. The KOH mount, however, was negative for fungal elements, but IV amphotericin B was started by ENT in anticipation. Patient systemically improved in the next 2 days, and CT scan was done immediately. CT brain showed chronic small ischemic vessel changes and age-related changes. On CT orbit and PNS, as we can see, there's bilateral pansinusitis along with attenuation and thinning of cribriform plate and other bones. In the findings in the orbit were suggestive of right side orbital cellulitis. Ophthalmic reassessment was immediately done, and as we can see, the vision in the right eye is deteriorated to PL positive, PR inaccurate bedside. There was conjunctival congestion and chemosis in the right eye, along with a fixed mid-dilated non-reactive pupil and restriction of EOMS in all gazes. On fundus examination, CRAO was present and absent sensations which were noted earlier. In the left eye, however, now we can also see the restriction of extraocular movements laterally with absent sensations in the periocular area. The nasal swab culture report now showed growth of Rhizopus species. Patient was taken up for FES and simultaneous retrobulbar injection was given in both eyes as patient had given negative consent for exentration. As we can see in the post-operative day 1 in the right eye, along with conjunctival congestion and chemosis, a yellowish tinge was noted in the conjunctiva. Other findings on ophthalmic examination was similar to the pre-op findings. Sadly, the patient succumbed the next day to his illness. Coming to the discussion, mucormycosis is an invasive lethal fungal infection, the most common species being the Rhizopus and the mucus species. It has various forms of presentation, most common being the rhinoorbital cerebral mucormycosis, which starts from the sinuses. Now, why is it that the disease which was once rarely seen is now so commonly seen across all states of India? The main culprit of this is the increasing number of COVID-19 cases which have been injudiciously treated with steroids, especially in diabetics, leading to uncontrolled sugars. Use of other immunomodulatory drugs like tocilizumab, use of unsterile water and oxygen humidifiers and contaminated masks has also been postulated. Mutants of COVID-19 virus, they are more transmissible and replicate faster, hence leading to a longer duration of treatment. Now, what are the indications of retrobulbar amphotericin B? It can be given in early disease, especially when the vision is unaffected. In cases where progression of the disease is there, while the fitness for surgical debridement of the patient is still in process. In cases of bilateral involvement, it may be given as a last resort, or if the patient is systemically unfit for any kind of surgery. Advantages are that it has better local penetration of the drug with lower systemic toxicity, minimally invasive, and a globe-sparing procedure. In a recent article published by Dr. Santosh Honawar, sir, he has also recommended the use of retrobulbar amphotericin B in early orbital disease along with sinus debridement. 1 ml of 3.5 mg amphotericin B is given through a separate syringe preceded by a local anesthetic in the intraconal space. It has a few local adverse effects, commonly being increased orbital pressure and the most deadly being orbital compartment syndrome. I did a comparative analysis of our study with other two studies, one published by Mustafa et al. And another by Christine Hirabayashi et al. As we can see, the vision at the time of giving retrobulbar injection in the other two cases was much better. the total number of injections in our cases was only one, as the patient succumbed soon after. But in the other two cases, 2 and 6 respectively injections were given. A significant visual improvement was noted in the other two cases. Also, along with systemic amphotericin B, other antifungals like micafungin and capsofungin were also given in those cases. Now, what are the challenges that we are facing today in treating mucor, especially in
1 minute.
COVID-19 patients? Thank you, sir. Angioinvasive nature and fast spread of the fungus lead to a high mortality rate. KOH mount is dependent on technique of collection and may be negative in up to 50% cases. Rampant use of steroids as seen in COVID patients, and management and control of diabetes in COVID-19 has been a real challenge for the physician. Long duration of treatment and poor compliance of patient. We as tertiary care hospital usually receive patients who have poor systemic conditions or in the advanced form of the disease. High cost of drugs also adds to all the other challenges. In conclusion, I'd like to say that in cases of COVID-19 positive rhinobutton mucormycosis, intravenous antifungals, reversing the patient's immunocompromised state and glycemic control, endoscopic sinus debridement immediately are the mainstay of treatment. However, as ophthalmologists, we should be highly vigilant and identify and pick up warning signs like periocular edema, regional pain, sudden diminution of vision, ptosis, redness, facial pain, etc. at the earliest in COVID patients. A low threshold for starting amphotericin B, especially retrobulbar ampho, should be present. None of the studies reviewed in literature mention the exact timing and dose of retrobulbar injections, and there is a need for further research in this case. However, with the knowledge that we have currently, it should be tried as an adjuvant in early disease prior to exentration in COVID patients. These are my references. Thank you, sir.
Dr. Purva,
Yes, sir.
what is the earliest sign of orbital mucormycosis?
So the patients have presented with various signs, sir, like even congestion, just simple conjunctival congestion or chemosis, which has later aggravated.
One more question.
Yes, sir.
Why there is sudden emergence of orbital mucormycosis suddenly at present? We are treating COVID-19 patients since last 1 year.
So in last 1 year, the highest cases which was seen in the day was up to 2 lakhs. However, there have been increasing number of cases which have seen up to 4 lakh cases per day has been seen this year, sir. Also, the mutant which is there is more transmissible, leading to higher number of cases. And injudicious use of steroids even for mild COVID-19 has led to increasing number in this second wave, sir.
Any other questions? Till that time, Purva, you can stop sharing your screen and the next speaker can share the screen.
Yes, sir. Thank you.
Any other questions for us?
Dr. Mansi More.
Yes, sir. So may I start?
Yes, you can start.
You can start, Dr. Mansi. Yeah.
Good morning, everyone. Myself, Dr. Mansi More. I'll be presenting a case on persistent hypertropia following modified Nishida for a monocular elevation deficit. I would like to thank you, BOA and MOS, to give me this opportunity to present this case today. My patient, 48 years old female, came with the complaints of drooping of right upper eyelid since birth, decreased vision in the right eye since childhood, and history of ptosis surgery done twice in early childhood with no records were available. She was nil systemic by illness. On examination in the right eye, patient's unaided vision was 660, which was improving to 624 with plus 1.25 DSP, and a near vision of N12 with plus 1.75 addition. In the left eye, the patient's vision was 618 parts, which was improving to 6.6 with plus 1.50 DSP, and a near vision of N6 with plus 1.75 addition. In the extraocular movements in the right eye, there was -4 limitation of elevation, and in the left, they were full and free. Pupils in both the eyes were central, circular, and reactive to light. On modified Klimsky's test, in the right eye, there was 45-degree right hypertropia with no esotropia or exotropia seen. This is a 9-gaze photo of my patient, where in the primary gaze, we can see there is hypertropia present, and also there is elevation deficit, limitation of elevation in all the other gazes. So on ptosis evaluation, there was severe ptosis obscuring the visual axis, loose papery skin was seen, a frontalis overaction was present, poor to nil levator function, and an anterior posterior segment was unremarkable. So the diagnosis of my patient was a right eye congenital monocular elevation deficit with a moderate amblyopia with severe ptosis. On ocular investigations, the IOP of the patient was 14 millimeters of mercury in both the eyes. SAC was patent in both eyes. Forced duction test for inferior rectus was positive, and a forced general test for superior rectus was faint with no tuck felt. No diplopia charting was done as the patient didn't have any diplopia. MRI was done, which was within normal limit. It was done to rule out any acquired causes of MBD. Now, the plan of action was squint surgery followed by ptosis. FDT or FGT decides the surgical plan. So the forced duction test for inferior rectus was positive, and therefore inferior rectus recession of 5.5 mm was done. A modified Nishida was planned, and the correction obtained with the modified Nishida's procedure was 30 prism diopter, and in conjunction with the inferior rectus recession was around 40 prism diopter. Because it's a small series, the average correction needs to be refined with a larger series. Now, this is the methodology where a modified Nishida was done with a limbal incisions taken, a medial rectus and the lateral rectus muscle were identified, non-absorbable 5-0 ethibond suture used with the 1/3 fibers of the horizontal muscle anchored at the equator axis on the sclera in the superotemporal and superonasal quadrants 12 mm behind the limbus. This is the surgical procedure. Now on post-op day 1, patient had small exodeviation with the flick hypertropia. Elevation had significantly improved to -2 from -4. Ptosis was present. Patient was put on antibiotic steroid eye drops and asked to review after a month. So this is the clinical photo of my patient on day 1, where we can see the hypertropia has been improved. On the follow-up day at 2 months, a post-op residual hypertropia with 14 to 16 prism diopter was seen. At 5 month post-op, a 16 to 18 hypertropia with elevation limitation being -3 was seen. Now, this is a preoperative and the postoperative picture of my patient, where in the preoperative, we can see there is hypertropia, and a postoperative, there is improvement of the hypertropia, which was observed. A monocular elevation deficit is actually a failure in elevation of all the gaze positions of the paretic eye. It is currently classified into 3 subtypes according to the findings of the forced duction test, forced generation test, elevation saccadic velocity, and Bell's phenomena. So type 1 is a restrictive form with the positive results on the FDT for elevation, normal elevation forced generation test, elevation of a saccadic velocity, and the absence of a poor Bell's phenomena. Type 2 is a paretic form with a free forced duction test, a reduced elevation of a forced generation test, and a saccadic velocity, positive Bell's phenomena, which is seen in a supranuclear palsy. Type 3 is a combined form. Now, these are the surgical management of MED, the options available. First is an IR recession, where we get a correction of 3 prism diopters with 1 mm IR recession, helps to improve the poor Bell's phenomena. NAPS procedure can also be done, which gives a correction of 21 to 55 prism diopter with an average of 38 prism diopter. It's a well-established surgery. The demerits have been discussed later. We can also do a IR recession plus NAPS procedure, which will give a 28.6 prism diopter correction. An augmented NAPS procedure gives a correction of 30 to 40 prism diopter. It's a surgery of choice as it gives better results than NAP, and there is no need of resurgeries. A modified NAPS procedure allows the correction of a horizontal deviation with untouched inferior half, or a vertical recession or a resection can be done, where we do superior rectus resection plus inferior rectus recession. It spares the horizontal muscles for future division of horizontal deviation. The exact amount of recession and resection is not described. That's the demerit of the vertical recession. Now, the drawbacks of NAPS procedure: there is no grading in the correction with NAPS. There is large variability in the amount of correction obtained with this procedure. The tendency to drift towards
You have 1 minute.
Correction of a horizontal deviation becomes difficult, and the transverse muscle is already maximally stretched, which makes resection impossible. Now, discussion: why was there residual hypertropia in my patient? It was due to the knot slippage. Now, ways to tackle hypertropia is a superior rectus plication with the same eye, a contralateral superior rectus recession with the Faden procedure. We can undo Nishida and plan modified NAP, or a monorectus transplantation with a foster augmentation can be done, or a resection of inferior oblique of the affected eye can be also done. We took the patient back to the OT, and a monorectus transplantation with a foster augmentation was done, where the patient showed improvement. On concluding, a modified Nishida procedure is simple to perform. It corrects vertical deviation on par with established NAPS procedure. It involves no tenotomy or muscle splitting. It is a reversible surgery with less traumatic to the eye, making it useful procedure in cases of MED. That's the references for my study. Thank you.
Dr. Mansi?
Yes, sir.
What do you think? Which procedure is better, modified NAPS or modified Nishidas, in comparison to results?
So I think modified Nishida is a better procedure.
Which is feasible.
So modified Nishida is also feasible procedure. That's what I think.
Okay, the next, any more questions, judges?
Mansi, can you hear me?
Any more questions?
Sir, we can continue.
Yeah. The next presenter is Dr. Jinil Bhatt. You can start sharing.
Good morning, everyone. Am I audible?
Yes, you continue.
Okay. I'm Dr.
Yes, go
Jinil
ahead.
Bhatt, first year resident of Ophthal, and I'm going to present Fueling the Fire COVID-19 aggravated rhino-orbital mucormycosis manifesting as orbital apex syndrome with retinal artery occlusions. So COVID-19 infection, a multisystemic inflammatory disorder, invites other comorbidities to play along. As if our battle against COVID wasn't enough, rhino-orbital mucormycosis seems to be hitting an additional blow. COVID-19 infection, its treatment, resultant immunosuppression, and pre-existing comorbidities have made patients vulnerable to secondary infections like mucormycosis. Black fungus, as it is popularly known, causes an invasive fungal infection occurring in diabetic and immunocompromised patients. Although we are not sure about the exact pathophysiology of interaction of the virus with the mucor, rhino-orbital mucormycosis is characterized by vascular invasion with hyphae infarction and necrosis of the tissue by an acute or subacute course. Co-infection with COVID may aggravate it, leading to orbital apex syndrome with arterial occlusions requiring multidisciplinary treatment. The fungi colonizes the sinonasal mucosa and enters the orbit through ethmoid and maxillary sinus or via the nasolacrimal duct. Ocular involvement often presents as an orbital apex syndrome and rarely as retinal artery occlusions. Mucor presents as external ophthalmoplegia, proptosis, ptosis, visual loss, chemosis, and other symptoms, while retinal artery occlusion, a rare manifestation of rhino-orbital mucormycosis, presents as an orbital apex syndrome with an incidence of 16 to 20%. This is attributed to the direct infiltration of central retinal artery by angioinvasive fungal infection from the orbit. My aim is to study the ocular involvement in COVID patients diagnosed with mucormycosis infection, focusing on the orbital apex syndrome and retinal artery occlusion at a tertiary eye care center. So, my being an ongoing cross-sectional observational study performed at a eminent Western Tertiary Eye Care Institute has a current sample size of 16. And after taking the consent of the patient who visited our OPD or who were referred from COVID hospital, the demographic data, ocular and systemic complaints were noted. A specific note was made about the systemic illness, including diabetes mellitus and the hyperglycemic index of the patient. Detailed history about the COVID infection and its treatment was taken. We noted the visual acuity and intraocular pressure wherever possible, and anterior segment and fundus evaluation of the patient was done using slit lamp biomicroscopy with 90 diopter lens. In non-ambulatory patient, bedside examination was performed by torchlight and binocular indirect ophthalmoscope using 20 diopter lens as per the status of the patient. Ocular movements of the patients were noted. So, of the many cases, I would like to present this one case, which is a representative of my sample. He shows the clinical signs of lid edema, chemosis, and proptosis, while his MRI image shows periorbital inflammation and involvement. On fundus photograph, it is depicting of central retinal artery occlusion, and when the sample was sent for culture, microbiology reported septate hyphae, which was suggestive of rhizopus fungus. So what the ocular signs we observed? Mainly, we observed lid edema in almost all the patients. Ophthalmoplegia was present in nearly 90% of the patients, and almost 2/3 of the patient had profound visual loss. Retinal artery occlusion was seen in almost 56% of the patients, as compared to 16 to 20% in non-COVID patients noted by other studies. So my observation is we had a good turnout in OPD of mucor cases. Almost 78% of the cases were more than 50 who had suffered from retinal artery occlusions. We had 25% of mucor cases which were females, and in of all the samples we noted that 3/4 of the patients, 3/4 of the males were more affected by retinal artery occlusion. So although this being majority of unilateral entity, we also noted some bilateral cases. Majority of the patients were suffering from diabetes, and of them almost 3/4 of the patients had poor glycemic control with HbA1c more than 8. So our study of 16 patients noted that signs of rhinoorbital mucormycosis had aggravated when it occurred with COVID-19 co-infection, which was even more in diabetics. So in discussion, I would like to say that lead edema, ophthalmoplegia, and profound visual loss were the most common signs in majority of our subjects. OPD patients were a little more than referral, which might be suggesting of an increasing awareness about the disease. Old age and male gender were probably the non-modifiable risk factor, and bilateral cases, although rare, but should be kept an eye upon. As Dr. Selman reported a case to warn of the possibility of COVID-19 in his study by triggering diabetic ketoacidosis, which could predispose an invasive fungal infection, our study had similar observation. As Dr. Muthukrishnan noted, retinal artery occlusion and orbital apex syndrome in mucor cases in immunocompetent patient, we noted its fulminant form in COVID-infected patients. Orbital apex syndrome, a common feature of mucormycosis, might be exacerbated due to COVID treatment, specifically in diabetic patients. As noted by Dr. Lahanesar et al., presence of diabetes or altered glycemic profile increases the risk, while our study had a similar observation. Whereas most of the studies showed a male preponderance, our study has almost one third of its sample as females. So we would like
1
to
minute.
dare suggest an hypothesis that we cannot rule out the fact that COVID infection being a coagulative condition and mucormycosis being a vascular invasive pathology by itself might be increasing the risk of ocular artery occlusions. The limitations of our study was due to the COVID being a new identity. Cases were difficult to trace or follow up, and this we had a small sample size. So I would like to conclude saying that orbital apex syndrome and retinal artery occlusions are dreadful ocular involvements in COVID patients with mucormycosis. Their early detection and timely management can play an important role in saving these eyes and reduction of morbidity and mortality. So we would like to send home a message that ophthalmologists are an indispensable soldiers in this war against COVID, and their coordination with other medical disciplines might change the scenario to a life-saving one. The COVID tide might settle, leaving behind debris of rhinoorbital mucor being one of them, which would require immediate attention. These are my references. Thank you. Hello?
Jinil,
Yes, sir.
Dr. Jinil,
you talked about early intervention. So
yeah, there
Yes,
was
sir.
a
in your study, don't you intervene early in any case?
Yes, sir. We do intervene in early case, but initially, while I started my study, I noted that most of the cases were from reference. After the awareness was so, while the patient presented to us, they had almost lost the visual prognosis to no PL, and total ophthalmoplegia was noted in them. But now, due to this ongoing awareness, even a simple periorbital swelling brings the patient to us, and early treatment is started.
What are your indications now to intervene early? So
Sir,
we have only one modality, that is retrobulbar injection amphotericin B.
Yes, sir.
In which cases you are giving?
Sir, we have a protocol of sending MRI orbit and paranasal CT scan in all the patients suffering from periocular lead edema, and after culture biopsy for fungus. And as soon as the fungal report comes, we start with peribulbar injection of around 3 mg per 2 ml.
Yes, we should not wait for progression. We should intervene early so that we can
Yes,
get
sir.
better results.
There was a question from Dr. Gadekar madam. She has asked that did you notice any common factors in bilateral disease, Dr. Jinil?
In bilateral disease, the thing which I noted was that they had a glycemic index of more than 11. HbA1c value they had of 11, and they were on long steroid treatment, and most of them were on BiPAP or on constant oxygen and were admitted in the hospital.
Okay.
Hello?
Any more questions, judges?
No, sir.
Okay. The next presenter is Sneha
Thank you, sir.
Kukreja. Dr. Sneha?
Yes, sir. Just say.
Yeah, you can start. Yeah.
Good morning. Myself, Dr. Sneha Kukreja, first year resident. I would like to thank BOA and MOS for giving me this opportunity to present the case. My case is multifocal intraocular lens in children with unilateral cataract, a boon or bane. An 18-year-old girl came with complaint of diminution of vision in left eye. She had a history of left eye cataract surgery with multifocal done 5 years back elsewhere. Prescribed glasses elsewhere with several follow-ups, but was not compliant with glassware. On examination, in the right eye, she had clear lens. Left eye, well-centered diffractive IOL was present with PC opening. IOP was within normal range. On fundus evaluation, she had 0.3 to 1 cup disc ratio in both eyes. On Wirtz 4 dot evaluation, she had left eye suppression. Stereopsis 400 arcs second with pseudo flight test. She was diagnosed with posterior molar cataract in left eye with vision 624 and was advised cataract surgery, which she underwent elsewhere in October 2014. A multifocal IOL Vayner plus 23 diopter was put as per records. In 2015, when she came for follow-up, she had developed myopia, slight myopia, requiring 0.5 steer in right eye, and left eye she was unaided 624 and improving to 6.9 parts with 0.75 spherical and 0.5 cylinder at 160, near vision being N6. In 2016, her left eye correction required was more, 0.25 spherical and 0.5 cylinder at 160, improving to 6.9, and this time her near vision was N8. In 2018, her left eye correction was in minus 4.5 spherical and minus 1 cylinder at 160, improving again to 6.9. And this time she required near vision glasses also around plus 2.5. Her unaided near vision being N18. So there was a myopic shift of around minus 5 spherical diopter with also need of near add in the multifocal eye in a span of 5 years. Why multifocal was chosen for her? Limitations of some monofocal IOLs in children with unilateral cataract are probably limited depth of focus. Monofocal IOLs cannot provide clear vision for distance and near. Monovision techniques may be helpful, but some patients but involve sacrifices in binocularity, and reading spectacles are required. Some review of literature show that multifocal IOLs being effective in pediatric age group, with up to only 2 children requiring, in this particular literature, 2 children requiring additional near correction. The queries that need to be addressed when choosing IOLs. As this patient was 12 years old when cataract surgery was done, she was probably treated like an adult, and these factors were considered. Centration problems, as this was considered. IOL power calculations, she was probably treated as adult, so the emetropia was targeted. Use of silicone oils, since Rayner was used, which is an acrylic IOL, so it was a better option, and the centration problems were also not present there. Embryogenic effect of multiple overlapping images in case of multifocal IOLs is present. Then there is decreased contrast, tolerability of glare that needs to be considered by choosing. 1 diopter of uncorrected corneal astigmatism may impair image formation in a multifocal system. Posterior synechiae also to be considered. Now, proper IOL power is difficult. Benefit from multifocal optics, the postoperative distance diffraction should be very close to emetropia. There is formation of multiple images in multifocal IOL, so it may prove to be a stronger embryogenic stimulus than ordinary optical defocus alone. Will decreased contrast sensitivity also present in case of multifocal IOL further contributes to amblyopia. Glare is again a recognized drawback of multifocal designs. Queries as such, Was she an ideal case for multifocal? This totally depends on the operating surgeon. However, as care should be taken in case of pediatric patients. Did the multifocal achieve the goal it was?
You have 1 minute.
As the multifocal IOLs purpose is to not require refraction, in this case, this was not achieved. What next for her? There are a number of available options. Prediction of myopic shift per operatively should always be considered, and targeted refraction is always 0. Take-home messages. Caution should be used when considering the insertion of multifocal IOLs in children outside of research protocols, especially in children who are at risk of amblyopia. Corneal astigmatism should be considered greater than 1 diopter in the surgical eye. Can cause further disruption of images. Associated ocular pathology present, such as corneal or iris abnormalities, uveitis, or microphthalmos. Caution should be taken in cases of traumatic cataract, lens decentration, pupillary abnormalities. Converting these considerations will convert the potential advantage of multifocal optics into a liability. Thank you.
Dr. Gadekar madam has asked. Hello, Dr. Sneha.
Yes, sir.
Yeah, Dr. Gadekar madam has asked, how much refractive error do you get for each millimeter increase in axial length?
For each mm growth for about more than 2.5 diopter. One mm increase causes 2.5 diopter.
Okay. The next presenter is Dr. Millie Arora.
Yes, sir. Good morning, sir.
Yeah. Go ahead, doctor. Share your screen. Hello.
Hello. So could you see my screen? Hello.
Yes, continue. Yeah.
Yeah, you can start, doctor.
Okay, thank you, sir. Good morning. I'm Dr. Millie Arora, and I'm a second-year ophthalmology resident, and today I will be presenting Perinaut syndrome. My case, an 18-year-old girl presented to the OPD with chief complaints of acute onset of binocular diplopia, especially on waking up from sleep when looking up and down. The duration of the diplopia was since 1 week. There was also left-sided headache and left eye pain associated with the diplopia. There was no history of projectile vomiting, transient visual obscuration, diminution of vision, or photophobia. There was also no history of trauma or any other prior medical conditions. Neurological symptoms were absent. For ocular examination, for the right eye, my patient's best corrected visual acuity was 6.6 with minus 1.25 cylinder at 180, and left eye being 6.6 with minus 1 cylinder at 10 degrees. Anterior segment for both eyes were normal. Posterior segment was normal. On demonstrating EOM, there was minus for elevation restriction and minus to depression restriction in both the eyes. Pupils demonstrated a light near dissociation. There was also characteristic convergence, distraction, nystagmus present and a Collier sign present, which is bilateral lid retraction. This was the 9-gaze photo of my patient, which demonstrated orthophoria in primary gaze and a minus for depression, minus for elevation restriction and minus to depression restriction. This is a video that I'll be showing of light near dissociation, wherein there is no reaction of the pupil to light. However, there is reaction to pupil to a near reflex. This other video showing the extraocular movement restriction, especially convergence and elevation and depression. As you can see, there is a restriction of movement, especially up gaze and down gaze. After which an MRI of brain and orbit was advised to the patient. MRI brain revealed a tiny acute non-hemorrhagic infarct in left half of the midbrain involving the pre-aqueductal gray matter. MRI orbit showed no significant abnormality. Thereby, a prompt referral to the neurology department was done, such that the patient received the prompt treatment. The neurological department investigated the patient thoroughly. Thereby, the basic investigation, including the CBC, ABG, chest X-ray, ECG, 2D echo, CSF analysis was normal. There was also a thrombophilia screening taken place for the patient, which was also within normal limits. COVID RT-PCR was done for the patient, which was also negative. And autoimmune profiling was done for the patient, which also came out to be negative. The general condition of the patient was fair, and the systemic examination was within normal limits. Thereby coming to a diagnosis of Perinaud syndrome with a midbrain infarct. So the treatment advised to the patient was low molecular weight heparin and antiplatelet agent. There was improvement in depression after 2 weeks, but elevation limitation had remained. Patient could not afford prism therapy. Since there was no improvement, since there was a lot of improvement, no surgical intervention was needed. Further follow-up only by telephonic conversation when the parents reported marked improvement. There was non-compliance of follow-up due to scare of COVID-19. Now, coming to the discussion of Perinaud syndrome, also known as a dorsal midbrain syndrome. This syndrome has characteristic features of up-gaze palsy, defective convergence, light near dissociation, lid retraction, which is known as Collier sign, and convergence retraction nystagmus. Etiology being in children, aqueduct stenosis, meningitis, pneumoloma, in young adults, demyelination, trauma, AV malformation, in elderly, midbrain vascular accidents and mass lesions involving the preductal gray matter and posterior fossa aneurysm. Meningitis, tuberculosis, or sarcoidosis should be ruled out. Pathophysiology. Now, why are we finding this up-gaze palsy? Up-gaze palsy occurs because of the involvement of the vertical gaze centers. These vertical gaze centers are in close proximity to the superior colliculus. The vertical gaze centers being rostral interstitial nucleus of the medial longitudinal fasciculus and interstitial nucleus of Kajal. Convergent distraction nystagmus is the other characteristic feature, which is characterized by an irregular, jerky nystagmus associated with convergence and retraction of both eyes, especially on attempted upgaze. Why this is happening is due to damage to the supranuclear fibers, which have an inhibitory effect on the third cranial nerve. So, since there is damage to the supranuclear fibers, there is constant stimulation of the superior rectus and the inferior rectus, thereby resulting in retraction of the globe. Now, one more characteristic feature, which is light near dissociation, happens due to poor pupillary constriction to light, but preserved constriction to convergence, like we saw in the video. This is because the pupillary light reflex fibers synapse at the pretectal nucleus and then pass to the Eddington nucleus of the same site, and the contralateral side through the posterior commotion, making them susceptible to external compressive effects of mass lesions. It's thought that the fibers for the near reflex are located more ventrally, thereby Investigation and treatment for this patient is neuroimaging, serological investigation, treatment of underlying etiology, prisms in case of binocular symptomatic diplopia. Bilateral inferior rectus recession can also be done in presence of abnormal head posture. To summarize my case, a classic presentation of dorsal midbrain syndrome. Characteristic triad was seen. Since all the investigation and evaluation was normal, etiology being embolic stroke of undermined source. Thank you.
Thank you, Dr. Millie. Dr. Gurudasani, any questions?
So in your case, you were satisfied with the neurological evaluation? Was it done by a proper neurophysician or?
So we also did a basic evaluation as an ophthalmologist. Then we referred the patient to the neurology department, which carried out a systemic neurology evaluation, which came up to be within normal limits. However, an MRI revealed the impact.
You don't investigate her for torch infections. Toxoplasmosis can be a cause for this condition.
I couldn't hear your question, sir.
Toxoplasmosis can be a cause for this condition. You haven't done torch, investigated for torch.
Yes, sir, could have been a possibility, but there was an infarct would have been a more possibility. That's why we went ahead with an MRI, because it had to be a very prompt decision and management had to be very prompt. So we first went ahead with an MRI and referring to the neurology department, which could actually manage the patient.
My worry was, as you told that the patient lost follow-up, that she was completely neurologically evaluated or she lost follow-up?
No, sir, she was evaluated, sir. Neurologically, she was evaluated definitely, but ophthalmically for a longer follow-up, that was a little difficult because of COVID-19, sir.
Okay.
Yes, sir.
Okay, our last presenter is Dr.
Thank
Nishika
you.
Jain. Yeah. Thank you, Dr. Millie Arora.
Yes, sir. Good morning, everybody. I am Dr. Nishika, first year resident. I would like to thank BOA and MOS to give me this opportunity to present my case. I'm presenting a case of type 3 Duane's retraction syndrome managed with lateral rectus recession with Y split. My case is a 10-year-old girl with complaints of outward deviation of right eye since birth, with gradual progressive diminution of vision in both eyes since past 3 years. No history of diplopia or glasses or patching or any surgical history in the past. There were no other systemic complaints or family history of squinting. Her pre-op 9-gaze picture shows us there is 10 degrees of exotropia, which increases on elevation, grade 4 upshoot on attempted adduction, and decreased adduction in the left eye. On examination, she had abnormal head posture of right face turn of 15 degrees. On sensory examination on word 4 dot test, fusion for distance was present. 100 arc second stereopsis on Titmus fly test. Hirschberg test showed 15 degrees of right exotropia. On alternate cover test, primary deviation of 20 degrees exotropia, and on secondary deviation, 30 degrees of exotropia. On ophthalmological examination, her extraocular movements showed -3 limitation of abduction and -2 limitation of adduction in her left eye, and narrowing and severe upshoot and downshoot on adduction. On the
She was diagnosed by left eye exotropia type 3 Duane's retraction syndrome, narrowing of palpable fissure on attempted adduction associated with severe upshoot and downshoot. Surgical correction was planned. On forced duction test, she was strongly positive for lateral rectus. A lateral rectus recession of 8 mm with Y split of around 20 mm vertical separation was done. The splitting of lateral rectus muscle lessens the lateral slippage of the muscle and recession reduces the torque. Post-operatively, patient had correction of head posture. She was orthophoric for distance and near, and there was complete disappearance of vertical shoots. Here we can see she was orthophoric and there was complete disappearance of upshoots and downshoots. Surgery. Other surgeries that are available are lateral rectus recession of the affected eye for exotropia and globe retraction, lateral rectus periosteal fixation for exotropia, abnormal head posture, and adduction. Introduction. Duane's retraction syndrome is a restrictive type of concomitant strabismus characterized by limitation of adduction or abduction due to abnormal paradoxic innervational impulses to horizontal recti, narrowing of palpable fissure, and retraction of globe on adduction, occasionally accompanied by upshoot or downshoot due to co-contraction of horizontal recti with globe slippage under a tight lateral rectus. It's a type of congenital cranial disinnervational disorder. Huber's classification showed that there are three types. Type 1, adduction more limited than adduction. Type 2, adduction more limited than abduction. Type 3, both adduction and abduction are limited. The other non-surgical treatments are correction of refractive error, treat amblyopia, presence of small abnormal head posture. Indication for surgery are large angle primary gaze squint, significant face turn, disfiguring retraction of globe, up or down shoot on adduction. Y split. The overshoot of the globe in adduction is believed to be the result of a bridle or leash effect caused by a tight rectus muscle that slips over or under the globe as the eye adducts. Y splitting of lateral rectus is used to treat upshoots and downshoots. The lateral rectus is split horizontally in half from the insertion, spreading the muscle around 20 mm apart or more, depending on degree of exotropia in primary position. Our patient improved with lateral rectus recession and a Y split of lateral rectus, thus proving the effectiveness of this procedure in type 3 Duane's retraction syndrome. Here we can see that the lateral rectus was split 20 mm apart and was sutured 8 mm behind the insertion. These are some literatures that proved the effectiveness of Y split with lateral rectus recession. Thank you.
Dr. Nishika,
Yes, sir.
was there any abnormal head posture in this patient?
Yes, sir. Right face head turn, sir.
Okay.
Ma'am, the pathophysiology is still unknown. Most of them say that it is due to the abnormal innervation to lateral rectus because of the sixth nerve. So because of sometimes the third nerve supplies both the lateral and the medial rectus, and that's why it leads to co-contraction.
Hello.
Yes, ma'am.
Yeah. Any questions, judges?
No, sir.
Yeah. Madam Gadekar has asked a question, Dr. Jain. Do you know myogenic theory?
Myogenic theory of autoregulation, sir.
Yeah.
Myogenic theory of autoregulation, it states that it's like an intrinsic property of blood vessel. It's more specific to vascular smooth muscle, and it regulates the vascular tone in response to the intraluminal pressure.
Okay. Thank you, Dr. Nishika.
Thank you, sir.
Yeah, we are finished with our presenters today. I thank all the presenters for their excellent presentations. And I also thank the judges, Dr. Manjunath Patil, Dr. Sarika Gadekar, and Dr. Bhavishya Gurudasani. Thank you.
Thank you,
All-
sir.
Yeah. Judges, they will mark the points and hand it over to the BOA members. And I think we'll end the session now. Give it.
Thank you, sir.
Thank you.
Thank you, ma'am.
Thank you, sir.
The next session will be starting by 12 o'clock.
Hello. Hello. Sai?
Yes, doctor. Yes, doctor.
Technical team, can you please help Dr. Pankaj Shah with the case?
1 second, 1 second.
Hello.
Hello. Yes, doctor.
Hello, sir.
Yeah.
Sir, I think Dr. Pankaj Shah is having a problem with voicing. He's not able to. He's unmuted. He's still not able to speak. Can
Am I
you please?
audible?
Yeah, we are able to hear you now.
Yeah. I think you are muted from your end.
No, doctor. I think you wouldn't have joined audio. Now it's audible.
Now it's audible, no?
Yeah.
Okay. Thank you.
Welcome.